My name is Dr. Raj Pyne. I'm an interventional radiologist. I work at Rochester Regional Health in Rochester, New York. CLTI patients are some of the most rewarding cases we do, but they're also some of the most challenging and occasionally some of the most frustrating cases we do. Typically, the biggest challenge is that of heavily calcified lesions. And if you break that down, typically heavily calcified lesions, especially at flexion points, which are challenging to treat. And the other one that typically also bothers us is really poor outflow below the knee. So those are the biggest challenges we see in CLTI patients. Over the last 10 or 15 years, the technological advances have been incredible. The techniques have advanced. And so now, really it's essentially everything that we are able to see typically is at least amenable to treat endovascularly. That's the great part. So at this point, the endovascular treatment is pretty much the first line for everything. And then surgery is typically a backup for bypass and hopefully really trying to avoid amputation at all costs, because we know the spiral that goes down for morbidity and mortality for patients once amputation is done. So the treatment typically for calcified PAD is, obviously getting across a lesion, finding the lesion, and then getting across it. I typically always start with POBA, plain old balloon angioplasty, to see how that helps. Hopefully, obviously, there's no dissection or other injuries there, but that's typically, maybe back in the day that might have been good, but typically that's not good for any of these lesions, especially as heavily calcified lesions. So that's why I think, honestly, Shockwave IVL has been a game changer for me in my practice. So, placed there in places where you can't stent. So it's nice to be able to have a smaller balloon to be able to go down there and really open up a calcified lesion, which honestly within, only a few years ago would be essentially untreatable. So that's the algorithm. Again, I think it's been really my go-to device for anything with heavily calcified lesions. And it's really been an incredible device as flexion points where nothing else really will work. So I'm going to present a case here, which really sort of highlights how I used Shockwave IVL to really help this patient in a CLI patient with non-healing wounds. So case highlights, 61-year-old male, history of PAD, he's Rutherford 5 PAD. He's had non-healing ulcers for months. He has severe claudication. He could walk less than 50 feet. He has rest pain at night from his severe claudication. On exam, he had really non-palpable DP and PT pulses, faintly noted with Doppler. We did ABIs. On the right side, he was 0.55, and the CTA done showed heavily calcified lesion at the P1 and P2 segments with complete chronic total occlusion. So we decided, obviously, as we typically do, to bring them for endovascular intervention. We brought him into the angio suite. And then we did a right lower extremity angio. This is showing just a cone down view of the knee. Really, it shows flow completely occluded at the level of the P1 segment from that CTO we described. Heavily calcified atherosclerotic plaque. You can see it on the unsubtracted images and on the CT. You see all these collaterals arising from this area. So as we try to get across, we were able, with just advanced wire techniques, to get across. Then we did predilation. We used a POBA angioplasty balloon, a 4mm balloon. Really, it shows very small amount of contrast getting through there with flow. As expected, it failed to restore adequate inline flow across the lesion. But we did this mainly as a predilation for our Shockwave IVL. So this is the next image. Once we switched out for an 014 wire. So we advanced. This is a 4.5 by 60 millimeter Shockwave M5 Plus. We actually advanced it across the lesion. You can see it as it inflates. There's still a small waist there. We advanced and then we delivered 300 pulses. Those pulses come in 30 pulses at a time. We went across multiple areas, and then once delivered, it went pretty quickly. And here's our post run. So at the end of this, we do a completion angiogram, and again, it looks about 60% residual stenosis, but we have inline flow now. So this is, sort of one of my keys that I look for is strong inline flow right down the leg. There's still a little bit going on below in the infrapopliteal segments. So we fixed some of that. We thought this might be some vasospasm. We actually inject a little bit of nitroglycerin, and at the end, actually, this was less than a 10% stenosis. So we had really good infline flow. So this actually went beautifully. This is a very nice example of how, if you notice where the lesion is and how heavily calcified it was, it's right at the knee flexion point. Before this, I might have had to or thought about being uncomfortable with this long term, so I probably would have stented this despite it being across the knee. In this case, the beautiful part about it in this case is there was no issues of dissection, there's no distal embolization, no perforation, no vessel damage, and the nice part is no stent was required. So we wanted to see how this patient would do without a stent, so we gave them a little bit of time to see how they did. In the recovery area, immediately after the procedure, we actually got pretty good, strong, palpable DP and PT pulses. Within the next day, the patient states that, calling them, they said that the rest pain had already started to improve and they're starting to do better. And more importantly, obviously with these CLTI patients, the big thing is about wound improvement. So as we look at these, here's the here's the pictures. Initially, this is what his two dime-sized heel lesions look like. There was some dry gangrene. Some of them even had some wet gangrene on them, sloughing of the skin, very poor dry skin, and all the other stigmata that we see of CLTI patients. At 1 month, this is what he looked like with the wounds. There's 3 months later, and 6 months finally, essentially complete healing of the wounds. At this point, he's almost 1 year out. He says he does his riding lawnmower out in the yard. He walks upwards of 2 miles certain days of the week. So he's had really, really nice results, and that was without any other intervention after the SHOCKWAVE IVL. So I think, I use it all the time. I think it's a wonderful device, but it's really got a few main advantages that I really like to talk about. Number one is the ease of use. SHOCKWAVE is about as intuitive as you can get. If you have performed balloon angioplasty before, it's a pretty easy learning curve. I think I've talked about it before, but it's consistency. So I'll let you know that once I use this device, I'll get very good intraluminal gain. It'll break the calcium at a deeper level, and then allow me pretty much, no matter how calcified that area is, to perform whatever else I need to perform. And now lately, I've noticed that even at flexion points, again, I'm using it as the final device with really good results. The last advantage, I think, is the safety. Dissections, perforation, rupture, immediate occlusion of vessels. With the SHOCKWAVE, I've really experienced none of that so far. I've had a very good profile, especially with dissection, which is something that you really worry about in a lot of these areas. We have not had that. The other key thing, it's nice not to really worry about distal embolic. So I don't put any distal embolic protection devices in, and I've never had so far any experience of distal embolization. So those are the main three advantages of SHOCKWAVE.